and they wear off quickly within 2 hours with lots of dyskinesias. So the therapeutic window kind of shrinks over time with levodopa, unfortunately, but it's still the most effective drug we have. Doping agonists are also available to treat Parkinson's disease, and these are better for your younger patients or younger relatives. So 70 on down is probably a typical age that most folks could do well with doping agonists. They have a longer half-life, like 6 hours, 12 hours, depending on which one you look at. And in monotherapy, certainly rare to develop dyskinesias. It may help, in addition to levodopa, to reduce motor fluctuations, so you can reduce the levodopa dose. And unlike levodopa, which competes for dietary protein, these drugs do not interact with dietary protein. The problems are, let's say you give this to a 75-year-old man who comes in and he ain't sharp as a tack. He's got a few cognitive deficits. You can see some significant hallucinations. He can really lose it on these medications. So you definitely never use a doping agonist in anyone who has significant cognitive issues, because they can really hallucinate and lose it. Also, these drugs are not as effective as levodopa, and that's the other drawback. But they certainly have a good place for many folks. The good news is that all of the drugs, these 4 drugs that we talked about, there's Pergolab, the old one that's been pulled off the market because of the fibrosis issues, but of the cardiac valves. But ropinirole, pramipexole, bromocriptine, all of these reduce motor complications relative to levodopa. You have less wearing off and less dyskinesias over time. Well, how do you treat dyskinesias if a patient comes in with those, the twisting and writhing movements? You can actually reduce the dose of the levodopa, or you can reduce the dose of levodopa or alter the schedule. You can add a doping agonist, which will allow you to reduce the dose of levodopa further. You can add amantadine to reduce the dyskinesias. Also, if folks have wearing off where the medication's not lasting very long, the levodopa that is, you can add a doping agonist there. Increase the frequency of levodopa. If they don't have much money, you can make the levodopa, let's say, go from 4 times a day to 6 times a day, and then shorten the dosing interval to help them. Or you can add a COMT inhibitor like entacapone, which is COMT10, or add tolcapone, Tasmar, to that to see if you can reduce the wearing off. Also, zytosylegiline and rasagiline are options to reduce wearing off as well. How about deep brain stimulation? Unfortunately, DBS does not stop progression of the disease. Okay, the disease still marches on. And we consider this after medical options have been exhausted. Certainly, patients should not expect, like the video shows from the company, Medtronic, should not expect that it's going to completely and utterly change their life 100%. No, it's equal to their best levodopa on. So in other words, when they take their Cinemet, the best they could be with that is what the best they could expect with deep brain stimulation. Hopefully without dyskinesia, that is without the writhing and twisting movements, they can also really improve tremor. The 2 biggest targets for folks to expect to improve are tremor and dyskinesias, and the slow movements can also improve as well. But if someone has a lot of tremor that's not responding to levodopa or doping agonist therapy, or a lot of dyskinesias, this option is certainly very useful for them. It probably provides a little improvement for gait and walking difficulties, and does not improve the postural instability at all. It may make it worse. It also may make speech worse. We commonly see new speech difficulties, and it doesn't make you any smarter either. So anyone under consideration for deep brain stimulation surgery cannot have significant dementia. They may have a little cognitive decline related to their Parkinson's, but if you're demented, it's a no-no. How does DBS work? Well, first of all, the neurosurgeons put an electrode into the brain. Frequently they use electrophysiology, recording the area of the brain to make sure they get it in the right spot. And then they attach it to a wire that comes out under the skin and to a pacemaker in the chest. Nowadays we have a pacemaker that drives both sides of the brain. You don't need to have 2 pacemakers, so you can put one in the right chest, and it actually has wires up to both sides of the brain. So you can leave the left chest open for a cardiac pacemaker. But these pacemaking devices then stimulate the brain at a high frequency, and you can adjust the stimulation through a programmer attached to this, going through the skin to change the parameters to make the best effect for the patient. So The targets that we typically go for are the subthalamic nucleus, or STN. It's the little yellow guy there in the left-hand picture there. As you can see, it's quite a small target. And then you go for the thalamus. For folks that have essential tremor, you can help improve the tremor by stimulating the thalamus. When you get to the STN, as you're putting the electrode through the brain, it's certainly, when you get there, you hear a sudden firing where it's really going crazy. And what the deep brain stimulation does is essentially actually stimulates that area and turns it off so that it more normally regulates the firing pattern of the nerve cells in the brain. Well, there's some recently released drugs for Parkinson's, including apomorphine, the injection. This is hard to use. Really only neurologists use it, and mostly movement specialists prescribe this. But it's an injection that lasts about 45 minutes, and folks can have lots of dyskinesias with it, but it does turn them on if they suddenly turn off with their levodopa. If they're in the grocery store, they can pop this sucker in their leg, and the dopamine agonist, which this is, stimulates folks to get moving again quickly. It works very quick within a few minutes. So it's a great drug for certain folks. Rasagiline, as I mentioned, may have some neuroprotective qualities. The jury's still out on that, and may slow disease. We're not sure yet. You may have heard of the patch. Every patient that came to our office was saying, hey, how about the patch? When's that coming out? The patch isn't nothing fancy. It's a dopamine agonist like ropinirole, like pramipexole, that is Mirapexin and Requip, same kind of drug. I used it in patients. We were only allowed to prescribe lower doses, at least as a single patch, when it first came out for early Parkinson's patients. I'm not so sure it was quite as effective, despite the literature, as the oral dopamine agonists, but it certainly, some folks in other settings have said it's been great, but certainly it can cause patch reactions of the skin as one problem, but it was a good option because it allowed smooth release. And if you had me, I don't take any medications, but if you had me trying to take a medication 3 times a day like the typical dopamine agonist, I'd screw it up. I'd definitely miss the midday dose many times. So once daily dosing with a patch every 24 hours probably certainly increased compliance in many of the patients. And it may reemerge in 2010 or 2011 once they get some formulary issues worked out. It actually had crystals that formed in the patch matrix that prevented delivery of the drug, and so the FDA made them pull it, and they're having to reformulate it. Kind of an expensive investment, but we'll see. Zydus selegiline is out there. It's a sublingual selegiline that's absorbed under the tongue in the vasculature there. Unlike what a lot of people think, Parcopa, you may have heard of that one, which is a Cinemet orally dissolving tablet. Parcopa is not absorbed under the tongue. It actually has to be swallowed down. It just doesn't require water because it dissolves. But zyduselegiline is and can help folks with wearing off. Rivastigmine has also been approved for Parkinson's disease dementia recently, and it actually has significant effects for reducing the ravages of the dementia over time in patients with PD. It also improves hallucinations in a study that was published, so that's an interesting effect, maybe a good adjunct to atypical neuroleptics. Slowing progression, how about this? Question 5. Okay, what drugs are currently under study to slow the progression